cartilage injuries, full thickness cartilage injuries, that would be a grade 4 cartilage injury, are a problem because your knee's broken down all the way to the bone. And if you're young and healthy and active, then we're going to assume the rest of your knee is normal, and you have an isolated pothole in your cartilage. Let's say you're under 40 and you have that. Most people would treat that and want to get it to seal over and not break down further or turn into arthritis. You want it to remain focal and maybe seal over so that it doesn't progress onto an arthritic lesion. So when you look at the options for that surgically, in the old days, say the 70s, we used to just go in with a shaver, smooth it up, and buzz the bone and make it bleed. That's called an abrasion arthroplasty. That works not so great, probably. So I think that's a little bit more of a historical type operation. Then we went into the era of what's called marrow stimulation. Everybody's heard the term microfracture. And what that is tapping through the bone into the cartilage, making little holes in the bone. There are different ways of doing it. You can tap in with a little pick, which creates a little stellate type of microscopic crevicing in the lesion and little holes. And I kind of think of it like golf cleats, where you're helping the blood clot and healing area there kind of gain traction so that it doesn't just fall out. And those marrow elements that come into this lesion to heal it kind of pool up and create a clot, and then the theory goes that turns into a scar-type cartilage called fibrocartilage. And so there was a real wave of enthusiasm for microfracture during the 90s. It requires a lot of protection. You have to stay on crutches for 8 weeks. You have to use a CPM machine to help you bend your knee. And the problem with microfracture is that there were maybe one main surgeon in the U.S. that was really promoting it. And as the results came in from independent studies, we found that really most people felt like the results weren't as good as we were being told. And so rather than having a 90 or 92% success rate, we're looking at more like 50 to 70, maybe 70 at best. And the problem with the group of patients that don't get better with microfracture is they kind of get worse. So you're taking a risk of getting worse in order to hope that you have a 50 to 70% chance of getting better. So as it was kind of borne out here in the early 2000s, everybody looked at that and were like, I don't know about that. I've seen a lot of patients get worse with this. You hear some famous stories of athletes having it done. It made them worse, and maybe the indications for it weren't great. Who knows? But it's one of those operations that can work, but it's not guaranteed to work. And if it doesn't, it can be a problem. It can make it worse. Then we went toward moving plugs. That's called an OATS procedure. It's you're moving plugs. Well, you're robbing Peter to pay Paul. So you're not really filling it up with a true contour. If it's a bigger lesion, that might be good for a small lesion where you just move a little plug. Almost anything works for those little bitty ones. If it's under 8 or 10 millimeters, you could probably just debride it and be fine, or a microfracture works fine, or a plug would work fine. But if it's a bigger one, you put several plugs in there, it's kind of faceted like a diamond, and it's not really an arc that's a smooth contour. So that's not ideal. Plus, where you took it from is usually a little bit more symptomatic than people thought it would be. You have a whole new generation of different kinds of cartilage paste you can put in there. Juvenile cartilage that's kind of morselized or minced, and you kind of put that in a paste. That does involve opening your knee generally and putting that in, and you have to be fairly protective of it, and it doesn't always heal in. There are other types of powder, allograft, what's called biocartilage. It's a mixture of morselized cadaver cartilage. It's not living cartilage. And then there's autogenous chondrocyte implantation, where you harvest the cells from a patient's knee with one surgery. You go to the lab and culture them, and then you come back and implant them. And the first generation was we would take a membrane and sew over that. We'd open the knee up and put the paste in there and then sew it up with a membrane around it. And that's just called ACI, autogenous chondrocyte implantation. And then in Europe, there was a huge study in Europe done with the second generation of that called MACI, an acronym. It's a matrix of autogenous chondrocyte and then implanted. And what that is that's kind of a membrane, and the cells it soaks up the cells like a sponge. And then you put that in, and you're gluing that in. And all of those procedures are giving you something that kind of resembles cartilage, but it isn't cartilage. If you look at human cartilage under a microscope, it is a very complex architecture. There's a superficial layer of very dense fibers and cells, and then there's a middle layer that's kind of like a lattice work of fibers and cells in there and columns of cells, and then there's a calcified layer at the bottom. So it's histologically or under the microscope, it's a very complex structure. None of those operations really restore normal cartilage. And so they can be kind of like that east-west punt return operation we talked about, where it's a lot of work and a lot of rehab and maybe not all that much yardage gained in terms of getting better. And then the final category is actually transplanting living cartilage. The tissue banking industry has just made huge strides in the science of that. And so we understand the basic science of tissue banking for cartilage and preserving it and keeping it sterile, keeping it alive. It's not frozen. It's refrigerated in a nutrient-type medium that keeps those cells alive. So it's kind of like a kidney transplant or heart transplant where you're getting living cartilage, and it's structurally normal cartilage, like a kidney would be a structurally normal kidney. It's not morselized or minced up kidney tissue. It's a kidney. So when you get these cartilage transplants, you're getting structurally normal living cartilage, and it's already bonded to the bone. All you have to do is create a little socket, a shallow cylinder socket for it, and you key it in, and that gives you bone-to-bone healing. And once the bone's healed, then you have normal cartilage, and it's living. So I think that's for larger lesions. Most people have migrated toward that option. I think it gives a better option for true, normal, slick, healthy cartilage that's living. It's been shown now, there's a lot of data, it's been shown to heal well about 94, 95% of the time. Even if for that 5 or 6% of people that do wind up having a problem with their graft, you can put another one in and it's still 94 or 95%. So the results are good. We've done it in athletes. Based on those results that I was quoting, we've pushed the limits a little bit with some good athletes, NFL players. I mean, we have about 8 or 10 out there that we've done, and it can be very, very durable. Once it heals, then their pain goes away, it tracks smoothly, it feels normal to them, and it's proven to be a very durable thing. I don't think it's a little cavalier to say something's bulletproof, because nothing's 100%, but these are good odds, good numbers, and it does truly restore normal cartilage. So if that's your goal, to restore cartilage, that's probably your best option.